If Manish will be late, we can continue, no problem.
I think, Dr. Hiran, we can start. So it will take time. So
Aarti, give me a signal.
So, sir, it's 3, 2, 1. Over to you.
So, very good evening to all the delegates. I'm Dr. Hiren Prajapati, General Manager at Iris Medical Affairs. Welcome you all on our today's scientific webinar. What should be your choice to reach the target lipid level? This is a webinar where we will get insight from the expert about the choice of selecting the statin therapy for achieving the target and lipid levels in various situations, various conditions, in various patient profile. So our expert will give the insight about this lipid management using the statin therapy for achieving the target LDL and how low and how much we can go, how better we can control our patients. That will be going to be discussed in today's meeting. So for our today's meeting, we have a moderator with us, Dr. Sanjeev Shah. Dr. Sanjeev Shah is a cardiometabolic physician in private practice. He's working since last 40 years. He's also working as senior diabetologist at Nanavati Max Super Specialty Hospital, Mumbai. Dr. Shah did his clinical pharmacology at KM Hospital and also the research in global clinical trials in diabetes since last 20 years. Dr. Shah has around 50 original research studies and 20 book chapters to his credit in various national and international journals where these studies are published. Along with Dr. Shah, we have an expert panelist in our today's meeting. So I would like to welcome Dr. S.N. Rautre, sir. Dr. S.N. Rautre is a former professor and HOD of cardiology at HCB Medical College and Hospital, Cuttack, Odisha. Sir was also faculty of cardiology in Medical College of Odisha since between 1992 to 2024. Is a president of Indian College of Cardiology. Also, the examiner and the MCI assessors in the DM and DNB cardiology exam, having more than 80 publications in the index medical journals. Also contributed chapters in textbook of cardiology and medicine updates. Also reviewer in many peer review high impact index medical journals like Indian Heart Journal, JAC, Asia, Curious, BMG case reports, and Journal of Clinical Medicine. So I would also like to welcome Dr. S.N. Rautre on the virtual platform. Here, we have another expert with us, Dr. Manish Bansal, sir. And Dr. Manish Bansal is a Senior Director, Clinical and Preventive Cardiology at Medanta, the Medicity at Gurgaon. He's a trained at Prime Institute in India and abroad. The recipient of many awards and honor to his credit. His expertise in the clinical management of wide spectrum of the cardiac diseases, which include the coronary artery events, valvular disease, cardiomyopathies, and also early detection of atherosclerosis, and some advanced technology like echocardiography and interventional echocardiography. Having a keen interest in the academics and the research, having more than 250 publications in various national and international journals. To his credit, he's also editor-in-chief of in Journal of Indian Academy of this echocardiography, and former editor at Indian Heart Journal, and also the former editor and board member of JAC Imaging and Cardiovascular Ultrasound. So, with this brief introduction, I would like to now invite all the experts and the moderators on this virtual platform for further proceeding of our today's scientific webinar. Over to you, Dr. Sanjeev Shah.
Thank you, Dr. Hiren, for those kind words. It's my pleasure to be part of this meeting along with two experts, Dr. Manish Bansal, who would be joining in few minutes' time, and Professor Rautre from Cuttack, from two different parts, one from north of India, another from eastern India, and I am based in Mumbai from western India. We are going to have an interactive session. You will not be seeing too many slides, but you will get plenty of wisdom from three senior expert panelists. And our topic is what should be the choice of drug in order to reach the lipid target, which have been revised. The drugs had been there for quite some time. We are almost 25 years from the time of launch of statin in India. And right from the days of loa statin onwards, we had different statin. So statin science is not new. Lot many papers have been published. A good sizable data exists on statin, and it has become an extremely important discovery, like insulin, penicillin, and statin, which has saved many, many lives. When we look at what results into cardiovascular disease, coronary artery disease, atherosclerotic vascular disease, you would try to think that which three risk factors are important: hypertension, diabetes, or dyslipidemia. When an analysis was done, which one is more culprit out of the three, it was automatically, the data was suggesting that lipid abnormality is a major culprit. And in order to prevent cardiovascular disease, arrest the progression of coronary block, though we should be treating all the three disorders A, B, C to the target, but most important still remains an LDL to be achieved at goal. Significant amount of data has been published more relevant to Indian patients because we are the people with low HDL. And so non-HDL becomes an extremely important, where an element of intermediate density and VLDL are also taken care of. High triglyceride is being taken care of if you have a total cholesterol minus HDL as a non-HDL entity. And this is one of a recent paper which showed how every millimole increase in non-HDL is associated with higher and higher risk of cardiovascular disease. So there is a distinct linear relationship and the doubling of risk when the level doubles. And so we should be addressing both, not only total cholesterol and non-HDL, but our major target and easier intervention is looking at an LDL number. And we learned long back, and the lab continues to print that 130 is all right. When the science has moved far ahead, you please do not look at 130 as a normal LDL. We would discuss in a short time. So the same paper showed that LDL is a major cardiovascular disease. Lower the number, better it is. And I would like to take a opinion of Professor Rautre here. Dr. Rautre, Kaushik Ray from UK published a paper in relation to lifetime exposure of LDL. In the past, we were not treating people at the age of 30 and 40 in absence of other risk factor. I frequently see health checkup has revealed an LDL of 140, 150, 130. So what's your opinion regarding asymptomatic hypercholesterolemia? They are not familial hypercholesterolemia, but they have an abnormal LDL value. And your expert opinion in relation to long-term cumulative burden.
Yeah, good evening, Dr. Saha. Good evening, everybody. This is very important part what you have mentioned in the sense that the total cholesterol burden or total LDL burden, what Kaushik Rai is telling, the level of cholesterol and the duration, how long it is remaining. So you have to detect quite early so that we can know that how long it has remained in the higher side. That is a total cholesterol burden. Second thing, what important you told, this is the only LDL which has improved the Cox postulate. That means if LDL is increased and your chances of atherosclerotic coronary disease is increasing, and if you treat LDL and bring it down to the target, then the atherosclerotic coronary disease is decreasing. And if you again it increases, again the chances are increasing. So that is directly related. There are so many factors, but only this total cholesterol and LDL cholesterol in particular is related to atherosclerotic coronary disease. And the cholesterol burden, the total cholesterol burden. That is very important because say sometimes we are not estimating cholesterol at a younger age. So once the patient become adult, unless there is a familial problem, this should be total lipid profile should be estimated so that we can know his level, and at time to time we can estimate if it is high, and accordingly we can know the total burden. So total burden is high means even if patient is asymptomatic, that likely that he is going to suffer from atherosclerotic cardiovascular disease. You will have to calculate the risk. How the risk, 10-year risk, 20-year risk, what is the risk? So risk score again, for Indians, no definite risk score is till now done, but still what scores are there by the Westerners, that is quite good. I mean, estimating the risk score. If risk score is high, then we'll have to treat. That is the main purpose. Yeah.
Thank you, Professor Rautre. So initial 5 years, if a person is untreated, he has accumulated the burden and he would require more aggressive later on, whether he would manifest with a clinical endpoint at what stage, at what age would be seen in the future. But it's our duty as a good physician to offer him a solution because there is no risk in relation to long-term statin use. So if we look at the two different data of 2023 from European Heart Journal and Clinical Lipidology, which has given us a different LDL goal. For people with a moderate risk, as Professor Rautre highlighted, the risk equation, Q-risk scoring, which matches with more Indian settings and it takes care of multiple risk factors. ASCVD risk scoring is easily available on an application, and this will give you next 10 years risk whether patient is at 7%, 10%, 15% or higher risk. Based on the amount of risk, the LDL target is determined below 100. Nowhere it is above 100 for people even with a low risk. High risk people requires below 70 milligram LDL and of more than 50% risk reduction by a treatment. Lipid Association of India, primarily Raman Puri based in Delhi and other associates, Sadanand Shetty and many others, are more aggressive. But here there is significant amount of matching with the European Heart Journal. In couple of years, CSI guideline, Professor J.P. Sahni published in December 23, also talks about similar kind of a risk-oriented LDL target. So let's see, the first question here comes to how a physician has to act. If you see the left side box, treat to target, are we aiming 100 milligram as an LDL or a 70 milligram? But if you see the baseline is 140 and you reduce to 100 by a particular dose of a statin, it is considered as 30% reduction. But if you reduce from 140 to 70, it is a 50% reduction. So Dr. Rautre,
Yes.
what do you think should be the strategy
Yeah.
of 30% versus 50%?
Yeah, this is very important and tricky in the sense when we're reducing the cholesterol, you see this purely says reduction of cholesterol. So cholesterol target or LDL target. So LDL target is different and ASCVD risk prediction and target is different. So ESC says you go 30%, 50% to achieve less than 100 or less than 70, whichever is what Lipid Association India clearly says in moderate risk, it should be less than 100. If high risk, it should be less than 70. If it is very high risk, it should be less than 50, where ESC said it is 55. And in extremely high risk, it should be less than 30. So what would mean? So that percentage reduction is okay, but depend each patient is separate. His cholesterol, LDL cholesterol has to be seen accordingly. Say somebody is having 160, for example, so reduction of 30% comes above 100. That means nothing. But you will have to bring it below 100. That is required. The reduction of LDL cholesterol percentage is different, but target is always a number. So target is moderate risk less than 100, high risk less than 70, and lipid association go beyond, that is less than 55, where it is high risk, very high risk in ESC. That is why I will tell you here one thing. The recent paper they have come out, lipid association, Dr. Puri, Dr. Sethi, what you told, they have come up, the level of LDL cholesterol or total cholesterol is different in Indians compared to Western countries. So what we tell for Western countries 70, our cholesterol is 10 milligram less than that of the age and sex matched Western population. So our target should be less than their target. We do not have own data, but this is the hypothesis. They have already published a paper recently in 2024 that says our with measuring this LDL cholesterol or lipid profile and comparing, they have shown our level is less. So they are quite justified bringing down LDL cholesterol more than that of the Europeans. So I will say, both are okay, but we should stick to the target. That is less than 100, less than 70, less than 55 or 50, whatever. And in very high risk, extremely high risk, less than 30.
So as a physician, one would think that a patient with extremely low risk would still need a 30% reduction with a low intensity statin, and rest others will fall into moderate risk into 50% or higher than 50% reduction in LDL level. Let's move to the next topic. I was always impressed by cholesterol treatment trialist collaboration data. This included as high as 28 trials, but 21 trial had almost 1.3 lakh individual, close to 5 years follow-up. They compiled the data from multiple trials, and this data got published around 2010, approximately 10-12 years after multiple lipid-related trials were published. So let's look at some of the findings, what was here. So this is the data from 26 trials. Dr. Rautre, this is something which is interpretation of all the 26 trials.
So actually this 26 trial, as you told, they have taken up to 2010, they are 26. This 26 trial here, if you see this, 5 trials are comparing high dose statin to low dose statin, and 21 trials statin with placebo. So 1,30,000 that is with placebo, and rest around 40,000 that is with high and low dose. If you see high end dose and low dose like Provit, A to Z, all of this TNT, they're compared high dose with the low dose. And other trials like 21 say about WESCOPS and ASCOPS, and Jupiter, their primary prevention trial, secondary prevention like 4S, CARE, lipid, all these things they are with compared with the placebo. So this is the they have taken into account any trial at least 1,000 number, and they must be followed up for 2 years. But they have found out in the 5 trials, that is the lipid low and high dose, there are 40,000 patients, and their follow-up was for 5 years. And this other 21 trial follow-up for 4 to 8 years in different trials. But very important thing they have achieved, they have detected that the risk reduction of any major cardiovascular event is around 22% per 1 millimole. So total reduction and per 1 millimole reduction of LDL, what is the percentage they have calculated? And this is very important. And again, reduction of MI and CAD, the risk reduction is about 24% for any risk and 27% for non-fatal MI and 20% for fatal MI. So if you see here again, coronary revascularization, maybe CABG, maybe PCI is around 25% and 25% surgery and 28% PCI. Stroke reduction, all stroke 16%, non-fatal stroke 23%. So this is a large reduction. If you see, almost if you can single a number, if you remember 20, the reduction is around 20 in all. Maybe CV events, maybe stroke, maybe MI, maybe non-fatal. All these things you can remember. 1/5 reduction of the events occur by 1 millimole reduction of LDL, that is 38.67 milligram per DL. And this thing they have seen in both the trials, all the trials, the similar results they have got. So not only there is the LDL reduction, but also benefits as regards preventing stroke, reducing the CV events, reducing the non-fatal and fatal MI, non-fatal and fatal stroke. So finally they came, each 1 millimole reduction in LDL cholesterol is associated with 1/5 events reduction, irrespective of the baseline cholesterol concentration. Again, this is very important. Irrespective of the baseline cholesterol may be say 160, 130 or 90, in spite of the if 1 millimole reduction of LDL is associated with, and 2 to 3 millimole reduction is associated with 40 to 50% reduction in risk. This is very important. So if you target reducing the LDL by 2 to 3 millimole, then definitely the benefit is enormous. And lowering the LDL cholesterol to less than 70 milligram is a desirable in high-risk individuals, as we have seen earlier in the studies and in the ESC and Lipid Association of India guideline. And such target can be achieved with high-dose statin. Say you can say rosuvastatin, if it is high dose 20 to 40 milligram. If it is atorvastatin, it is 40 milligram to 80 milligram, and or ezetimibe combination. This will come later on. We have the combination with rosuvastatin with ezetimibe or atorvastatin to ezetimibe. That further details will be there in the coming slides.
Thank you, Professor Rautre. Now we look at this finding when it comes to diabetic population. Are these diabetics at a real high risk of cardiovascular disease? Over the years, multiple papers and studies have shown that 75% of diabetic patients will eventually develop cardiovascular disease in lifetime. Steve Hafner, long back in ERIC studies, showed that diagnosis of diabetes should be considered as equivalent to MI, but those data were challenged subsequently few years down the line. But Navid Sattar from Glasgow, a brilliant epidemiologist, showed that 10 years duration of diabetes is definitely a high risk and equivalent to MI. And so onset of diabetes less than 40 is also extreme high risk. 10 years duration is high risk. 70% having hypertension in diagnosis with diabetes are extreme high risk, and 30% having microalbuminuria, having a diagnosis of CKD, are at high risk, as well as now in last 3-4 years, emerging science on obesity and GLP-1 RA has cumulative data of high BMI is also high cardiovascular risk. For Indians, unhealthy lifestyle, unhealthy food habits, sedentary habits, smoking, pollution are additional risk factor. But in addition, Indian ethnicity is again another point on which I would request Professor Rautre to comment when he is discussing on the next point in relation to pure hypertension in absence of diabetes. This is a BMJ paper which looked at views on statin in hypertensive, And the second point to comment was Indian ethnicity, Indian genetic background, why Indians are at higher risk for cardiovascular disease. Over to you, Professor.
Thanks. You see, here in the graph, they have shown the events like all-cause mortality, coronary heart disease, this cardiovascular problems, cardiovascular and stroke. All these things increase if the systolic blood pressure increases from 120 upwards, and diastolic blood pressure increases 80 upwards. And it has been seen that adding statin, particularly it was seen in ASCOT LLA, lipid lowering arm, but there atorvastatin 10 milligram was added. So if you treat hypertension, then definitely you are reducing the events and all these problems. And when it was added, unless I added in ASCOT LLA 10 milligram atorvastatin, those group of patients had enormous benefit. So this study was discontinued in the sense that the placebo arm, they were given atorvastatin because the benefit, they cannot be deprived of the benefit what it was. So it was prematurely terminated. So that's why definitely there is a benefit. But all said and done, if somebody is having hypertension, no dyslipidemia, no other comorbidity, no diabetes, etc., there is a question arises in our mind whether we should give statin or not. But what Dr. Saha now told, the Indians are different. Indians, they're more of multiple risk factor, conglomeration of the risk factor from the younger age. So like diabetes, cholesterol, hypertension, other risk factor like smoking, tobacco, chewing, etc. are there in younger persons, particularly Indians, and they definitely benefit on adding statin low dose. So I think there is evidence has shown there is definite benefit in this subset of patients.
So let's move our subject a little forward. As we have discussed diabetic and hypertensive, as it was shown, hypertension and diabetes are associated with multiple risk factors, insulin resistance being underlying with all this population. Now, coming to a subject of ezetimibe, ezetimibe was launched way back in 2002. It was not so much noticed as an important drug till the trial got published, which was called an IMPROVE-IT trial, got published in 2015. It took about 6 years to collect the data. Eugene Braunwald had been one of an important investigator whose team investigated over almost 5 to 6 years. Now, this particular trial got published in June 2015. They selected 18,000 plus patients who were discharged after hospitalization for acute coronary syndrome, whatever comes under that diagnosis, including MI, unstable angina, and everything. This was done at close to 1147 sites in 39 countries. Follow-up was done for a period of 6 years. Average age of participants was 64 years, and many patients had high risk factor like diabetes and hypertension as believed to be risk factor way back in 2008. All the patients received at that time a standard of care was the simvastatin, extremely popular statin drug. The dose of 40 milligram, all of you are aware, matches with 20 milligram of atorvastatin, and it matches with 10 milligram of rosuvastatin. That is what we learned in relation to efficacy of lowering of each three of the statin in patients with hyperlipidemia. Now, all these patients received simvastatin 40 milligram. They achieved a LDL of 70 milligram. At that time, it was a new concept whether reducing from 70 downwards would benefit or not. So they were randomized into half receiving placebo and half of them receiving ezetimibe, but it was added on the background of 40 milligram simvastatin, which in your mind you interpret 20 atorva or 10 rosua in a current scenario. What happened to these people would be interpreted by Dr. Rautre, how the findings are and what are the implications. If you see the graph here, simvastatin monotherapy patients maintain an LDL of 70 milligram because they received placebo, while those who received simva and ezetimibe combination, it reduced by further 17 milligram LDL. Whether this much reduction of LDL resulted into kind of a benefit, you can see here 7% reduction in primary endpoint compared to simvastatin group who maintain an LDL of 70 milligram. So further reduction from 70 to 53, and the benefit which was matching 18 milligram, if you reduce, you get a 6% reduction all along, which was a knowledge or belief got proved here also, though it was not a doubling of a statin, which does not give you 18 milligram reduction. Here it was statin plus ezetimibe. So Dr. Rautre, I need your comment on interpretation of IMPROVE-IT. Efficacy was seen in all three: CV death, MACE, and non-fatal stroke.
Yes.
And the second question after your interpretation is written at the bottom of a slide.
Okay. So actually, as you told, ezetimibe came long back in 2002. Not only that, it was approved by FDA for use to reduce the LDL cholesterol. This acts mainly by hampering the absorption. So this reduces the absorption of the cholesterol and lipids. So what happened? The earlier trial, whatever were done, they were not done to see it reduces the ASCVD events or not. That were done to reduce the cholesterol. So it was seen it was reducing cholesterol. However, because of certain side effects like mainly gastrointestinal side effects, they were not very favored for prescription. But this trial, this proved the reduction of ezetimibe with simvastatin compared to simvastatin alone is significant. That is, p-value was less than 0.016. So that was about 7% further reduction in CV events compared to simvastatin 40 milligram. That means that is, in spite of coming to 70 milligram per DL target, there is some existing, need to further reduce it that came with the ezetimibe. Not only that, the reduction was associated with the reduction of CV events. That came to, from that, now people are using ezetimibe. At present, the data shows around 6 to 7% of the lipid lowering persons using lipid lowering drugs are ezetimibe compared to 1.5% PCSK9 inhibitors. So now it has come as a second agent next to statin. So this has actually, did your practice change? People have changed their practice after IMPROVE-IT trial, and particularly there is reduction of the CV events. That is very important. All CV events were reduced, not only in addition to simvastatin. So that's why it has changed in my practice also. In many patients, I have added ezetimibe to the statin. Of course, what we are using either rosuvastatin or atorvastatin. At one point of time, ezetimibe was not available. When this trial came, we were not using that, was not available. Now the ezetimibe was available. Now the combinations of ezetimibe with moderate intensity statin has come. And that what I see, many of the experts there now using this combination.
Dr. Rautre, it is Eris in fact decided to offer you ezetimibe without any extra cost. And they kept 10 milligram, 20 milligram, 40 milligram and ezetimibe combination all at the same price.
Same cost.
So, yeah, so there is no price burden passed on to the patients if a doctor wants to use a combination. So let's move further on to the story of combination therapy. This is now
we have discussed this. Yes.
5% of Asian population took part in an IMPROVE trial. Statin has similar effect in Indian and South Asian with respect to efficacy and safety, and there are hardly any differences in pharmacokinetics of statin. So which patient characteristic benefit the most from combining ezetimibe with statin? I am putting it in a different words also for clarity for listeners, that you have two options whether to use 20 milligram rosuvastatin versus 10 plus 10, creating different 20 milligram. So how do you see selecting a combination in a which kind of a patient background? Why are physicians reluctant to increase from 10 to 20 or 20 to 40 rosuvastatin, which is again a big issue? Cardiologists use it very easily. Diabetologists and physicians do not increase and do not offer high intensity statin. They remain in moderate or low intensity statin.
There
Over
are
to you.
several points. Yeah, there are several points in your favor. Of course, you are right. We use higher dose because we use higher dose mostly in SCS patients, in acute coronary syndrome patients, either ST elevated MI or NST MI, where the statin has been proved to be definitely beneficial in reducing the event, not only by reducing the cholesterol, not only by reducing the LDL, but by the stabilization of the plaque. By that, it reduces. That's why we use up to 40 milligram rosuvastatin, 80 milligram atorvastatin. But all said and done, if you take higher doses, the chances of side effects are more, particularly statin-related muscle symptoms and other rise in liver enzyme, etc. may be there. If you go for a moderate intensity statin with ezetimibe, the same target you can achieve, same level you can achieve, and without much of cost, as you told, cost benefit will be there, and the adherence and compliance problem will not be there because they will be continuing that, and this side effect profile will less. So all these from multiple benefits, definitely this is a preferable combinations and should be used quite widely.
Thank you, doctor. So let's look at a different data. This is called Da Vinci study. Kaushik Ray and many other experts from Catapenno from Italy and others, Neil Porter from UK, published this paper of 18 countries in Europe. They looked at the guideline achieved or not in patients who are receiving lipid-lowering therapy. This is 2021 publications, and they look at 2019 guidelines were very popular in Europe in relation to. So this is what is the finding in a Da Vinci registry. 62% of the patients could not achieve the goal and they remain at higher level in spite of very high risk profile. High intensity statin was used only in 38% of very high risk patients, while moderate intensity combination drug was used. For clarity point of view, I have put it moderate intensity is here rosuvastatin 10 milligram, high intensity statin is 20 and 40 milligram. So 20 and 40 were not much used only in 38% of patients. But moderate intensity with ezetimibe combination was one of the options, as you said earlier, was used only in 9%. This is a period of 2016, 17, and 18, few years immediately after publication of IMPROVE IT trial. So I need your opinion in relation to why with optimized statin, there is still no non-statin drug which is added. Goal attainment is written here. High intensity monotherapy is only 20% in primary prevention, 38% in secondary prevention.
So what you told is okay, but what I told, because the long inertia of not using ezetimibe and this benefit what was achieved in IMPROVE IT trial by reducing the event, that was not properly used So I think if we would have used our knowledge, used the science that it has definite benefit as regards compared to high intensity statin, definitely in my opinion, the use would have been higher. But at the same time, there is inertia from the pharma company also. The pharma were not there. They were also not producing all these things because this when the science come, that should be utilized. That is the whole thing. I think,
Correct.
in my opinion,
You need a noise level, repeated
yes,
reminder,
yes,
multiple
yes,
brand.
yes.
Currently, it is happening with bempedoic acid. Hardly anybody has launched. People don't know about. While ezetimibe has become slightly more popular after CSI guidelines,
Yeah,
more
yeah.
teaching program.
Yes,
Yeah,
yes.
Professor Bansal is here. Dr. Manish, we just put up this Da Vinci study and how patients with high risk, they did not receive high intensity statin, 38%, and only 9% received moderate intensity with ezetimibe. 62% were not at goal. And so we were talking about why physicians continue with statin monotherapy and they are afraid of high dose. So they remain in moderate intensity category. They don't reduce 50% or 60% LDL level. So what's your expert comment on?
First of all, good evening, everyone, and my sincere apologies. I got stuck in the OT for a procedure, so my apologies for that. So regarding lipid lowering therapy practice in India, I completely agree with our faculty that the usage of appropriate lipid lowering therapy is very poor in India, and it's primarily because of lack of awareness regarding the necessity to reduce LDL sufficiently to obtain the desired benefit, and also patients' apprehension of unsubstantiated side effects of statin. So everyone is very, very apprehensive. They don't want to take statin. At the same time, physicians also don't realize that it's very important to lower LDL sufficiently. So both these reasons, we continue to find that the usage of uh, adequate lipid lowering therapy is low in India.
So people have a perception regarding poor tolerability.
Yes.
Statin associated muscle symptoms, physicians believe that 20% of patients develop. The extensive data indicate that only 9% develop statin-associated muscle symptom. There are methodology of excluding hypothyroidism, correcting vitamin D deficiency, switch over to Atorva or switch over to Rozua is again suggestion, but people should stay on a statin rather than eliminating the statin. Guidelines are where not popular. Maybe people take in a long history of ASCVD, but this slide is very, very interesting. This is 2025 publication in a journal called Drugs. And I tried to create that bottom part is moderate intensity statin plus ezetimibe. And the top part is high intensity statin, not effective for all patients, risk of side effect, physician inertia, poor treatment in adherence. While moving from high intensity or moderate intensity to ezetimibe combination is more cost effective, better adherence, reduced side effects. What is your expert comment, starting with Professor Rautre, followed by Dr. Bansal?
So actually, this thing is just we were discussing. This is my experience is that if you combine these drugs, definitely the side effect profile is less, and cost is definitely less, and compliance, or we can say adherence, is better. That is there, and whatever small number of patients I have prescribed, I am finding it is efficacious and also safe. So I think. My experience
So,
goes with this also. Yeah.
so more frequently you use this. Dr. Bansal, what about your secondary prevention, huge practice at institute? Any departmental strategy at a prestigious institute, Medanta's huge department? How do
Yeah.
you
So,
all
yeah.
collectively, a group of cardiologists, practice?
So actually, we recently conducted a study at Medanta, and this was published in Indian Heart Journal just a few months ago. So there we looked at all patients who had undergone revascularization during the year 2023. So 1st January to 31st December. And we found that in patients who were undergoing PTCA, most of the time they were prescribed rosuvastatin 40 milligram. But despite that, not even 50% were reaching the LDL goal of less than 55 milligram per deciliter. Roughly 65-70% were reaching the goal of less than 70. But I believe that we should target less than 50 to 55. More than 50 to 55 is not appropriate for Indian patients. So less than 50% were reaching that goal. When we combined ezetimibe in few patients, there more than 55% patients were able to reach the goal of less than 50. This was in PTCA patient. On the other hand, in case of CABG patients, the trend was to prescribe rosuvastatin 20 milligram as a default strategy. So their LDL levels achieved were even higher. So after conducting this study, for last few months, we have changed the practice. Now in our hospital, all patients who are undergoing CABG are receiving rosuvastatin 40 plus ezetimibe almost as a default, unless LDL is low. And in my own personal practice, I prescribe rosuvastatin 40 plus ezetimibe in most of the patients, or at least 20 milligram rosuvastatin plus ezetimibe. That is the minimum that I use, because our own data and many of the studies have shown that less intensive statin therapy is not going to reduce LDL to the levels that we want to reach.
Dr. Bansal and Dr. Rautre, there are also patients who have not come for follow-up. There are patients where physicians and primary care physicians reduce the dose of a statin. Those who achieve the goal, they say, now you do not require this much dose. There is a tendency in the mind of physicians to so-called help the patient by reducing the dose, and somehow we could be doing a wrong thing. That is also quite exactly, Dr. Bansal. This is what was done in this particular trial, which was long-term efficacy and safety of moderate intensity with ezetimibe. This is a Korea-based study. Exactly, somehow they got an idea of doing, but it's an open label, non-inferiority, 3 years, but number was phenomenally high. 3,007, close to 800 ASCVD patients, half receiving 10 plus 10. So they looked at a moderate intensity versus kind of rosuvastatin 20 milligram in a Korean patient. And this is the kind of LDL reduction what they observed. On the right bar diagram, you can see 10 plus 10 rosuvastatin achieved close to 74% reduction. Patients achieved less than 70. Of course, they have not looked at less than 50. But over a period of 1 year, 2 year, and 3 years, the graphs were different. Primary endpoint 9.1% versus 9.9%. Similar composite 3-point MACE. And this is what proved a point. As Dr. Bansal practices in high-risk individual, 20 plus 10 and 40 plus 10, I'm sure you will get 75% reduction in an LDL level. So what would be your expert comment on the finding of a racing trial?
I completely concur with these observations, because as I mentioned, this is what I've been practicing also. And it is true that if we block two different pathways, we get more benefit, because if we double the dose of statin, only 6% additional LDL reduction occurs. But if we add ezetimibe, we reduce LDL by another 15%. So a combination of rosuvastatin 10 plus ezetimibe 10 is going to get more LDL reduction than doubling the rosuvastatin dose, which was seen in this study also. So I agree completely with this.
Dr. Rautre, we discussed an IMPROVE IT trial earlier.
Yeah.
The first half. Now this is a different trial, which at that time it was simvastatin 40 milligram, which is equivalent to 10 milligram rosuvastatin here.
Yeah. But again, as you told, they should have targeted to 55 as per ESC guideline. But anyway, with their quite a large number of patients, achieved around 55 with this combination. With moderate dose intensity statin plus ezetimibe.
So Improve IT told us about 53 milligram way back in 2015 still remains highly relevant. As
Yeah.
we believe in 2025, we are looking at less than 50, and we would come to, as now or earlier also mentioned, that statin and ezetimibe has become far more frequently prescribed by cardiologists compared to statin alone. So this is our second last question. We have a last two questions and last 10 minutes of the session. This is lipid management guideline, and we also had a kind of a CSI guideline published by Dr. J.P. Sani as a first author, and the team of experts, all of you were part of those guidelines, where ezetimibe remains an early, right at the beginning. Rosuvastatin 20 I see at many places, and 10 milligram gets added. So guideline in India, what is your comment, Dr. Bansal?
Yeah, so if you look at these CSI guidelines, as per those guidelines, in patients with ACS, we should right away start with maximum dose of statin, that is 40 rosuvastatin or 80 atorvastatin plus ezetimibe. Because in ACS patients, it's very important to reduce LDL sufficiently and promptly. In case of stable ASCVD, the guidelines recommend that we start with statin first, 20 or 40 milligram rosuvastatin, atorvastatin respectively, and add ezetimibe later if LDL is not sufficiently reduced. So basically, message is that in ACS, we have to hit the LDL with the maximum force by using a combination of 40 milligram rosuvastatin and 10 ezetimibe. And as I already mentioned to you, we are already practicing this now.
Yeah, so this is becoming slowly now a standard of care at centers of excellence. And obviously, the patients would benefit when they achieve a good target, they comply with medication. This is the last question and the last 5 minutes of the meeting. Indians develop coronary
You're
artery
not
disease
not
10 years early. 50% develop below the age of 50 years. MI happen at much younger age. All risk factor of hypertension and diabetes happen in 30s, and metabolic syndrome and central obesity is also increasing. Indians are thin fat Indians with visceral obesity and insulin resistance. We also have low HDL, so high amount of non-HDL. With there is also one question in a chat box which we will take it. We hope there are a couple of more questions, but before we go to LPA, the question in chat box is LPA, so we keep LPA pending. Your comment in relation to
I think this question everybody will give their comments, which is very important, because what I will say, Manish will give icing on this. We do not have our own data. That is the whole thing. We are still depending on Westerners' data, and we are using our expertise, our knowledge to bring our guidelines. That is not truly our guidelines. That's why we will need to have our own data, because what it clearly says, our patients develop coronary disease 10 to 15 years earlier than Westerners. And more than 50% are below 50 years, more than 20% are below 40 years. And this multiple risk factors at the younger age, hypertension, diabetes, tobacco in the form of smoking or chewing, metabolic syndrome, central obesity. In the recent ICMR guidelines, so 39% of the Indians have central obesity. And atherogenic dyslipidemia, again, high TG, low HDL, small dense LDL, that is very important. All these are there in Indians. And as I told to the Lipid Association of India, recent publications, their opinion that our LDL should be 10 milligram less than the Westerners. So our aim should be still lower compared to Westerners. And it's genetic cause regarding the familial hypercholesterol, which is more common in Indian, than the Western counterpart. And lipoprotein little you have seen is more higher in our population compared to Westerners. This may be some genetic background. And regarding the lifestyle, all know the less of exercise, more of laziness, and all this food, etc., are there. And we are lean fat. Though we look lean, we have central obesity and all these things. So many metabolic factors are against Indians. In such a setting, definitely we should have our own data. We should have our own guidelines. And I will request particularly Manish, he is there in this field. He is doing so many patients with he will, because Medant is doing the study on this, he will give his further opinion on this part.
Yeah, so as you've already mentioned, and as Dr. Shah also enumerated the risk factors that Indians have and the reasons why Indians tend to have CAD earlier than the Western populations. My comments regarding this would be that I'm sure we have already discussed this also, that the statin trials have shown that regardless of baseline LDL, relative risk reduction per millimole reduction in LDL is same, which means that if the risk is higher, we get more benefit, more absolute benefit with same LDL reduction. Now, Indians are starting at a slightly lower LDL. So we have lower LDL but higher risk. The only way we can counter is by more aggressively reducing LDL. We have higher LPA, but for LPA, we don't have a specific therapy. Only treatment is more aggressive LDL reduction. We have higher prevalence of diabetes. Only treatment for that is more aggressive LDL reduction. We have higher remnant cholesterol. We conducted a study from India, from our institute, published recently in Diabetes and Metabolic Syndrome Journal, where we showed that if we reduce LDL more aggressively, then remnant cholesterol level also comes down. So for all these risk factors, only one answer we have, that is more aggressive LDL reduction. So therefore, we need to target lower LDL cholesterol levels than Western population. We start earlier because our population develops CAD much earlier. So we cannot wait for atherosclerosis to develop and then act. Studies have shown that longer LDL reduction leads to more benefit than more aggressive LDL reduction for a shorter period. So we need to have long duration LDL reduction, more effective LDL reduction, and more sustained LDL reduction.
Dr. Manish, there is a question: what best new drug in LDL reduction other than statin for reduction of LPA level, from Dr. A.K. Israni in Delhi? There is only one question in the chat box.
Yeah, so we know, see, statins don't reduce LPA, but PCSK9 inhibitor and inclisiran, these are the two agents which are currently available that can reduce LPA. Specific therapies for reducing LPA are also under development, will soon be available, but they are going to be very expensive. So that's the main problem.
Yeah, they are into called as Sirna group of drug. Multiple are in the clinical trial. We don't know when they will be launched and when they would reach India. But currently, inclisiran is very easily doable kind of a thing. Self-injection once in 6 months. MRP is 1.2 lakhs, available at 90,000, and few of my patients are injecting inclisiran with successful reduction in all lipid level. So those who want to use it, they can surely use it. And you will be able to get some literature on that. With this last question, if there is anybody who wants to ask a question, otherwise we are at a closing time. I would thank Professor Rautre, who had to leave at 9:30. I would thank Dr. Manish Bansal, who could make it in the second half of the meeting and could answer and share his wisdom, his practice, his centers, his publications, and everything. I hope V2 and V3 have done the job of putting the simple science of LDL, statin therapy, monotherapy, and a combination with ezetimibe. Over to you, Aries team, for final words. Dr. Hiren Prajapati from Medical Affairs at Aries. Over to you, Dr. Hiren.
Thank you, sir. Thank you for your moderating the wonderful this session. I would thank you, Dr. Manish Bansal, sir, for sparing some time, sir. I think it's why your comments are highly valuable, and I think we get some more insight from your experience, and our audience will get some insight. Also, I would like to thank you, Dr. Rautre, sir, for taking care of this first part of the meeting and having wonderful chat with him also about discussing the LDL cholesterol and the statin therapy. With this, I think we are closing the meeting. Thank you. Have a good day. Good night, sir.
Thank you. We close the meeting.
Good night, everyone. Thank you so
Good
much.
night.
Good night. Bye.
Yeah, thank you so much, everyone. So from here, I'm ending this meeting. Thank you.